Ellis. I'm a professor of social work over at the University of Akron, and this was developed. I'm a consultant with the ATTC network and was asked to develop learning communities on clinical supervision, which fits nicely within the timeframes for ECHOs. So what this one is titled is Productivity and Documentation versus Quality of Care. And we're just going to go into some dynamics with agencies regarding missions, how their business works, and some of the ways this is playing out, and maybe leave room for us to come up with some ideas how to fix this. So we are going to look at how funding mechanisms, impact productivity requirements, recognize relationships between productivity requirements, compassion fatigue, and staff retention, and look at methods to how to better balance this to ensure care quality. So some key terms I'm going to start with is a purchase of service model, which is how healthcare primarily bills for services and maintains its revenue. Another is a concept of value-based funding, which is a mechanism of funding that is being explored, agency budgets, and productivity. So for starters, and I have this fresh in my mind. I'm the PI on a couple studies at the University of Akron, and in 2018, and again this year, we did surveys on direct care workers and executive directors of behavioral health agencies as it relates to staff turnover, burnout, and a number of other things. And interestingly, we asked the same questions of the executive staff that we did of the direct care staff. And when it came to the questions of what do you believe is the leading cause of burnout amongst direct care workers in your organization, the executive staff chose pay, and don't get me wrong, everybody wants to get paid more, and vicarious trauma. So leadership, the decision makers, believe burnout is related to low pay and client-based interactions. Staff almost universally indicated that burnout for them was related to documentation mandates and productivity requirements. So right there, we have a disconnect between how leadership sees burnout and how the boots on the ground describe their stressors. It's the patients, the clients aren't what is stressing people out. Pay is something that whether you're at the higher end or lower end, most people know what the pay scale is going to generally be before they get into the industry. But it's that documentation and productivity that really is alarming to direct care staff. Now, fee for service just means it's a system. A physician, a clinical social worker, a psychologist, a nurse practitioner, they are providing a service or a skill. And that skill has a reimbursement rate over the time that they provide that skill. So if me as a clinical social worker, if I provide a diagnostic assessment for an hour, reimbursement rate for that would say be $100. If somebody's doing case management, any number of medical procedures, there's something called HCPCS codes, where almost every procedure you can name in healthcare has a code, and through that code is assigned a reimbursement rate. So you add up all those reimbursements and all those codes, and that's the revenue for the organization, and that's a direct byproduct of services delivered by the medical or behavioral health clinicians. Now, value-based care is something that's based on quality, and it relies on outcomes and accountability and the occurrence of positive outcomes. Now, this isn't something that's really taken hold here as much as it has other places. But what's very different about a fee-for-service model versus a value-based funding is in a fee-for-service model, uh, there is no patient success doesn't factor into that rate at all. It's just the procedure. It's the service that is billed. It doesn't account for patient success, whereas value-based healthcare does. So productivity is that percent of time spent with providing that billed service. So in agency A, we'll say that productivity requirements for physicians is 60%. That means of their time in a work week, 60% of those hours must be billing services. So it also means that if a physician wants to go to a CME training in Columbus, Ohio, it will make them a better physician. It will allow them to network in the community. It will allow them to network with their peers. It will allow them to get some new information where they can improve their practice. But while that physician is in Columbus at that training, the organization has an experience they call lost productivity or lost opportunity. And what that means is the physician, while they leave for a day to go to a workshop, that means that's about 6 hours that isn't billed and isn't revenue gained by that organization. So we're at a space now where some organizations are riding such a fine line. They hesitate to let their staff go to CME or CEU workshops because they're losing revenue when they do. Direct care staff or clinical staff who render the billable services. Indirect staff is all those supports. The administration, the administration support, the IT department, the people that clean the buildings. All those kind of staff don't bring in revenue. Who brings in the revenue is the clinical staff that bill the services. So revenue are the funds brought into the agency, and expenditures are the funds that the agency pays out, which is their business costs. So to make this simple, because on Friday, when it's 1,000 degrees with 99.9% humidity, people don't want to do math. So we're making the math real simple here. Now we're going to say there's an agency that does nothing but diagnostic assessments at $100 per hour. And if you add up their payroll, their insurance, utilities, or IT, their rent or mortgage, their maintenance costs, office supplies, marketing, consultants, legal fees, all that stuff, it adds up to $1 million exactly. So you would say that that agency, because their costs are $1 million, that would be referred to a $1 million agency, which in healthcare or even behavioral healthcare, that is a very small organization. So their break-even point is $1 million. So what they have to figure out is how they're going to earn that $1 million to break even. Now, if they have 10 direct service staff, 40 hours a week comes to 2,080 hours a year. You figure 2 weeks of vacation in some places, and it's 2,000 hours a year. And you have 10 direct service staff. That means all 10 of your staff have to provide 1,000 hours or 50% productivity over the course of that year to be able to break even with $1 million at that agency. So that's how agency budgets are forecasted. This is what our business costs are. This is how many staff we have. This is how much billable service we have to provide to break even. Now, what cripples that is healthcare costs rise. The two biggest costs for nonprofits are staff costs or payroll and healthcare costs for staff. So when healthcare costs rise, instead of $1 million, it goes up. Now, there's one agency that I know in Summit County, a relatively small agency, probably about a $10 million a year agency, maybe mid-size. And it had amongst its staff in 1 year, 2 heart attacks and 1 cancer diagnosis. The next year, when their insurance came around, during the next open enrollment, due to their risk ratio went up at that agency because a couple staff got sick, their insurance premium cost went up by 30%. So 30% is a lot. So now all of a sudden, just something as simple as a couple staff getting sick, which happens, their expenditures go up, and now they can't break even anymore unless something else changes. If you need a software upgrade, the expenditures go up and they don't break even unless something else changes. If there's some brick and mortar issues, if there's salary increases, if there's staff turnover, if one of those 10 staff leaves and they can't replace it for 6 months, again, that's lost revenue and the agency can't break even unless something else changes. There's also, if anybody's in private practice, you know this can cripple you, but high level of patient no-shows. You know, sometimes we have no-show rates with some patient groups of 50% or more. So it makes it difficult to forecast. And if that revenue isn't spent down, they can't break even. I know in Summit County, over the last couple of years, there's been several large agencies that have not been able to spend down their contracts with their funding boards just due to workforce issues, that they don't have enough workforce to spend down the money that's available to them. Now, how this plays out is how to raise revenue is going to essentially be to increase productivity requirements for your staff. And I've seen some agencies that 10, 12 years ago, they had 50% productivity mandates, but then they got new software, they got new IT, they changed their building structure, they have a couple of other administrators. And now those same agencies, their productivity rates are 70% for clinical staff instead of 50, just over a 10 to 15 year range, which literally means direct care workers are working harder for sometimes the same amount of money. So another thing out here, and this is a policy of an Ohio agency that shall remain nameless. And this is one of the ways that they came up with that they could increase their revenue. Now, they offered all of their direct service staff that participated in what they called a CIP program, that they would give them a jack of $20,000 pay increase on their annual salary with certain caps. But so if you're at an agency, you might be offered a $20,000 a year raise if you sign on to this new initiative. Now, what that initiative was or is data-informed scheduling, where they would be scheduled if they worked a 40-hour work week, they would be scheduled with clients at 100% productivity. So that means you would be scheduled over an 8-hour day with 8 hourly clients. So just one after the other, after the other, after the other. There was an algorithm built into the software that if you had 2 clients that were chronic no-shows, they would double book them in the same slot. So essentially, you would have there was opportunity where you might be booked at, you know, about 115% capacity for your daily schedule. You might have 2 clients show up for the same slot. So this is, on one level, it is good for agency revenue, but you could put in chat or just unmute yourself. How might this impact patient care? If you were to have your staff scheduled at 100% productivity. If this was you and your agency, and you had no time for scheduled lunch or documentation, how would this impact you in terms of your own work fatigue? Would it be worth the bonus? Would this impact patient care? And I can't see the chat. I don't know if anybody's putting anything in there. But this is just one way some agencies are addressing the revenue issue. Now, some context here. Primary revenue source is bill for services. Revenue has to cover all the direct and indirect costs in an organization. Reimbursement rates have remained stagnant for a number of years. They've gone up some, but they haven't gone up to the degree that their other costs have, like healthcare and payroll. And employee healthcare costs are rising, sometimes 2 and 3 times what they had been in years gone by. And in one state, and this was prepared for a national audience, the one state is Ohio, and it was when Ohio rolled out the BH redesign a couple of years ago. And the BH redesign was supposed to create a more efficient system, but it created so much additional documentation that, according to the Ohio Council that sent out a survey to all their members, the BH redesign, again, born to develop system efficiency, increased statewide administrative costs by $70 million, resulting in providers hiring an additional 1,025 billing and administrative staff. So ultimately, when you're bringing on new non-clinical staff or new non-direct working staff, you have to make up for that with increased productivity. Now, documentation we get to, it's really, we have to have it. It traces a path, in our clinical records. It serves as a communication bridge, a central document. So different disciplines, different shifts at a hospital can go to a single place and track a client's care with whoever has interacted with them over the course of their treatment. It ensures, message fidelity between clinicians. We write it down, we document it. Lab reports are in there. Everything is in the health record, but somebody has to put that in there. And then also with health records, we can take some of that data and aggregate it and analyze it towards looking at treatment outcomes. So we could build in preferred outcome measures into those electronic health records. And we can see if patients are making progress. And then we could track that progress amongst different patients and come up with reports for our internal quality improvement groups, reports for our board of trustees, reports for the community, any number of things. But all of this is tethered to documentation. Now, documentation, it's important. We have them in treatment so they can help learn how to live life and navigate life without behaviors like substance use that impact their forward trajectory. So ultimately, patient care is what we're in business for. Having patients heal, having patients or clients get better, seeing lives improve of the people that use our services. That's what the services are for. And it's due to that client-centered approach. Even if you look at licensure boards, whether it's the medical licensure board, social work licensure board, psychology or nursing licensure boards, those licensure boards are brought into existence primarily for patient protection. Is one of the reasons. So we always have to look at our services through a patient protection and a patient outcomes lens. And for that reason, we need to take a closer look at all this documentation in the lens of patient care to ensure that all of this data that we're asked to collect does not compromise clinical care. And what I want to ask you guys, and respond out loud if you can, or into the chat, is your current level of documentation at your agency, do you believe that is impacting patient care? Is the current level of documentation at your agency, something that fosters burnout? And how does it do that? If you look at your own experience in healthcare or behavioral healthcare, what are your biggest stressors? Is it documentation? Is it productivity? Or is it patients? Or is it pay? And if it's documentation, then one of the very things that we're asked to do to keep the businesses open and to communicate well might be interfering with what best practices are in patient care. Now, this is something that happened uh, when methadone programs came out. And methadone programs actually came out a little bit longer ago than that. I think the studies were about 1955 with Neisschweider, and then the first methadone programs were mid 60s. But there was a lot of federal rules that came into play with methadone programs. Many of those rules are still in play. And back in the late 70s, a leading expert at that time stated that these early adopters of these early methadone programs had to, quote, programs quickly learned that survival depended on the condition of their records and not on their patients. So again, we've known for a long time that the way we practice healthcare in the United States and the way we fund and bill healthcare in the United States has become a business more so, and we're maybe losing our focus on what we're here for in the first place. Because when those organizations come in, a lot of times they're looking at our records more than our patients. They're looking at our documentation more than our patients. And we know it's important. Nobody's going to disagree on the importance, but are we out of balance? Now, this is from, and for those that know me, I'm a motivational interviewing therapist, and I've been practicing this and teaching this for a long time, and I'm a big fan of it. So if I have a disclosure, it's that I really lean into motivational interviewing. Now, the developer of MI, Bill Miller, he practices in the Pacific Southwest in New Mexico. And there's a lot of indigenous populations, reservations, culture of the indigenous people, Native Americans in his area. And a lot of that culture has encroached on, other cultural belief structures. And it's even, come into the way that some healthcare is practiced. And Bill Miller, and he frames this as part of his what they refer to as the spirit of motivational interviewing, feels that he has to be completely centered in order to fully attend and be attentive to and pay attention to and hear clients that he's meeting with. So before every session, he stops, he takes a breath, and he centers himself with this little prayer to himself out loud. I don't know, but guide me to be a patient companion, to listen with heart as open as the sky. Grant me vision to see through his eyes and eager ears to hear his story. Let me honor and respect his choosing of his own path. As a therapist, he wants to clear his mind and be centered. And that is part of being a very effective therapist. That is part of the spirit of MI that lends to therapeutic alliance. If you want to, I could do a real simple cultural competency training in a sentence or two. That one of the most universal signs of respect throughout all cultures is being listened to. So as therapists, as healthcare practitioners, if we really pay attention to clients, if we really are eager to hear their stories, they will trust us a little bit more. But sometimes it might get hard to listen to a client if I'm seeing my fifth and sixth client within the last hour and a half, if I'm an emergency room physician that is doing 10-minute bedsides, every 10 minutes for 3 to 4 hours straight, where how do you get one case out of your mind in order to be open to the next case down the road? If you're in private practice and you're just constantly opening your door, letting someone leave and saying next, how attentive can you be? So we have to look at how do we clear space in our minds to be the best healthcare practitioners? And is our level of stress within our organization, is our level of stress with our documentation or productivity requirements interfering with that? Now, in a nutshell, we know that excessive caseloads and documentation have been identified in multiple sources as a reason why people leave organizations. Oftentimes, people don't leave hospitals. People don't leave mental health agencies. They don't leave them necessarily because of patients, in as much as they leave them because of the culture, because of the stress, interpersonal dynamics and supervision issues, any number of things. But excessive caseloads and documentations have been identified as causes of clinical staff leaving. Now, what these studies don't say is how often those departing clinical staff learn that the grass isn't always greener on the other side of the fence. Because the way our healthcare structure is laid out, a lot of organizations, have this same issue where we have to increase productivity mandates to make ends meet, or we have to increase documentation requirements just for an additional fund. I've written several SAMHSA grants, and federal grants are great. They bring money to the organization, they bring money to the community. But with every SAMHSA grant, there's things called GPRA, which is the Government's Performance Reporting Act, that requires us to collect even more data than we did before for the people that are getting services based on this additional funding. We've learned sometimes, well, with BH redesign is whether somebody's from Molina, United Healthcare or Medical Mutual, there might be different documentation required for pre-authorization amongst all three of them. So we still have, no matter where we go, there's going to be some of these documentation issues. So with supervisors, we run into this issue of what do we do? Do we increase productivity or do we improve quality care? Is there a way they coexist? Are we in a culture that leans us more one way than the other? Are we in some fiscal realities that lean us one way more than the other? And even when we get into clinical supervisors, clinical supervisors have two roles. One of their role is workforce development and staff development and ensuring model fidelity and helping their staff hone their skills. One of their other duties is administrative, which is ensuring productivity, ensuring everybody knows how to work the EHR, ensuring that documentation is done on time. And a lot of times supervisors' jobs are leaning more towards that administrative piece, and we're not having as much direct mentorship or clinical supervision as we had in days gone by. So some conclusions. Agency revenue is tied to billed services. Clinical productivity requirements have continued to increase as organizational costs go up. And it brings us to a question of balance. How do we balance agency revenue with quality of care? So these are just some potential solutions: of value-based funding, tracking clinical outcomes so that we know what the sweet spot for productivity is. I mean, at what point does a clinician become burnout? Is it at 70%? Is it at 75%? Is it at 60%? We have no idea. Because a lot of organizations don't really track patient success well. Maybe advocate at a state level to start allowing for reimbursement of non-clinical services. For instance, clinical supervision, could that be a billed service? Collaborating with a colleague, could that be a billed service? Or even attending a CME training, could that get some reimbursement from an outside source? These are the kind of things that will help take some of the air out of the balloon. Reduce unnecessary clinical meetings. We have a lot of meetings. I just did a study in Summit County, and one of the things we evaluated was coalition structure. And what I found out is there's a lot of coalitions, and a lot of times it's the same people that are on all the different coalitions. And there's a lot of meetings going on. Burnout reduction activities, which might not be what everybody thinks. A burnout reduction activity might be a CEO's idea of, we're going to take everybody to Cedar Point. I worked at an organization in Lake County a number of years ago, and that's almost exactly what we did. We had a mandatory staff fun day, emphasis on the word mandatory staff fun day. And it was out at Geauga Lake while it was still there. So I'm kind of old. And they have a water park. And I got to tell you, being around all my coworkers, with my dad bod and everybody in their bathing suits and swimwear, wasn't fun. It just wasn't fun. It was taxing. It was ridiculous, and it was stressing everybody. There was these uncomfortable giggles all around. And so somebody's idea of a fun activity might not be somebody else's idea of a fun activity. But some other burnout reduction activities is there's the Treatment Research Institute in Philadelphia. A number of years ago, their director was Tom McClellan, who has since started working for the federal government, and Denny Carisse. And Dr. Carisse did a study for the state of Delaware where they were contracted to do a paperwork reduction audit of behavioral health system in the state of Delaware. And all they did was get a list of all the required documentation that was required by the states, and took those to organizational leadership and took those to some of the advocacy groups and said, is this really needed, one at a time, with all these documents? And they were able to jettison about 20% of the required documents within the state of Delaware behavioral health care system by this simple audit. So there's things we could do that are outside of fun activities that might better help us reduce burnout if we know what the cause of burnout is. Ensure dialogue between business and clinical staff. Back in the early 90s, one of the best workshops I did is we got a new CEO at a nonprofit I worked for, and he got all the staff into a room and he showed us through spreadsheets and explaining it really well how the agency is funded. And I had been in the field that time, probably about 6 or 7 years, and it was the first time an organization ever explained to me as a clinician how the agency was funded. I really didn't know. And that allows the clinical staff to be part of the solution in coming up with some efficiencies. So I'm going to open this up to you guys. I'm going to, come back to see everybody's faces here. But some questions I have for you that I'd like to discuss a little bit with you if we can, is at what point does productivity impact client care, and how do you know? If you were a supervisor, what's more difficult for you, implementing organizational productivity requirements or advocating for staff? Because supervisors are in the middle. And lastly, what are some things that you can think of that might help reduce burnout or turnover at your agency? Or what are some things that helped relieve your work-related stress for when you weren't at work? So I'm going to stop sharing.